Okay, so a very good evening, everyone. So I hope my audio and video is clear and we can get started with the session now. Yeah, right. So we can get started with the session. So very good evening and welcome to the session about 25 most important questions in the topic of medicine for your upcoming FMG exams. So I'm Dr. Singaram, faculty at MIST, and I will be taking you through this session. So in the next 1 hour or so, we'll be discussing about the most important expected questions in the medicine part, where I'll put up the question options as the discussion also, as you have attended in the other subjects also. You can put up your comments in uh, the comment section below. I'll be able to see them and respond to them. Because your exams are near, we will keep it to the point which is needed for your exams without and cutting short the elaborate discussions. I'll make it to the point discussion for the upcoming 25 questions. Okay, right. So let us get started with the Right. So let us get started with the session. See, this is something which is going to be about the questions in an MCQ format, as you would expect, with some images as well as all type of question like statement type of question, one-liner questions. I've just tried to compile all of them in the 25 most important ones. Let's get started with the session. Yeah. Yeah, screen is bigger. No, this is being done through a Zoom application, so that is why the screen is a little bit smaller. Maybe mm, the technical team will take care of it, right? So we will get started with the session. A 45-year-old male presents with a daily headache. Okay, he describes 2 attacks per day over the past 3 weeks. So whenever you are encountering clinical scenario questions like this, you need to have some observations or the few keywords in the question. For example, this is headache in a middle-aged male and multiple attacks per day for the past 3 weeks. Okay, right? So this is not a single episode, it's a recurrent episode. And he goes on to describe the headache, saying that each headache lasts for about an hour and awakens the patient from sleep. What is the meaning of awakening the patient from the sleep? It is night episodes also present in this particular patient. The patient had noted associated tearing and reddening of the right eye. So this is something related to the right eye, where the patient is having tearing and reddening, as well as nasal stuffiness during these episodes. Now, whenever you get increased secretions in the form of tearing from the eyes, no secretion, it is nothing but increased secretions in these areas, or it suggests some sort of autonomic involvement. Okay, the pain is very deep, very severe, and limited to right side of the head, meaning that it's a unilateral headache. This is unilateral headache. Neurological examination wise, otherwise normal. Okay, right? That is what the question says. Okay, right. Now, if you put together everything which is given in the question and look at the options, what is the likely cause of this patient's headache? Migraine, cluster headache, tension headache, brain tumor. Now, out of this, brain tumor is very unlikely because we have seen in the question only the neurological examination is completely normal. Okay, right? So, brain tumor is definitely impossible. If you see the other three headaches, migraine headache, cluster headache, tension headache, this is what we study as types of primary headache. Primary headache means headache without any underlying reason is called primary headache. Okay, so all these three are possible. So let's do a quick approach to this question and then bring out the answer. Number one, it's a very severe variety of headache. Number one. Number two, it was unilateral, somewhere or other related to the eye region. That is what the patient was complaining, something or other related to the eye. And third is autonomic symptoms are present, right? And as most of you told the answer very clearly for this question, it is cluster headache only, right? All these are very characteristic features, okay? Cluster headache, in fact, is the most severe type of headache. Please understand that. It is the most severe type of headache, overall most severe type of primary headache. And also the location is very characteristic, one side surrounding the eye area, and also autonomic symptoms. Not only that, cluster headache is more common in males compared to females. That can also be the clue in your questions. Okay, right? So these are all things which made me think about the possibility of cluster headache. If you look at migraine headache is also unilateral, but it will involve one full face. Very important point. I'll show the picture shortly. And migraine headache is more common in females. Okay, that is another important point to be noted. So with all this, our diagnosis is cluster headache only. Let's quickly go through some important points. It is the overall most severe type of primary headache, number one. Number two, location, I already told you, it is something which is surrounding the eye or periorbital. Third is the treatment part. Okay, what is going to be the treatment part? The treatment part, acute attacks. Acute attacks should be aborted by giving which drug? I think all of you should be knowing this. What is the drug of choice for aborting an acute attack of cluster headache? Yes, triptans. And also oxygen therapy also helps, right? So for an acute attack, these two are the options. Next is about suppose this patient was having recurrent episode, right? So if you want to give long-term treatment, okay, right? Long-term treatment, which drug can be prescribed for long-term treatment? It is verapamil. Okay, to decrease the future episodes, you can give verapamil, which is the calcium channel blocker. Along with that, steroids also. Verapamil plus or minus steroids will have a role in the management, right? And as some of you correctly pointed out, it is 100% of oxygen. That is what. Okay, right? So these are all the treatment options in cluster headache. Now, prophylaxis, I've already told you, it is verapamil plus or minus long-term steroids. Now, if you see, this is a quick picture to tell you about the distribution of the different types of primary headache. Now, what is the first one? On the left side, you can see this headache I'm talking about. It is something like a band in the front of the head or the forehead area. Yes, this is the tension headache, which is supposed to be the most common type of primary headache also. This is tension headache. Second is what I was talking about. One full face is getting affected, more common in females compared to males. What is that? Yes, it's a migraine headache. Very important. And third is what we were discussing about, that is a cluster headache. Please look at the typical location which is surrounding the eyes, periorbital location, right? So this is a quick picture for you to remember about the three important types of headache needs to be remembered. Okay, right? Now, one more point I want you to remember is for managing the migraine headache and the cluster headache, it should be triptans, which should be the drug of choice, triptans. And for tension headache, it is something like a simple paracetamol will work. Paracetamol will work. Right. So this is like a quick outlook of the three important types of primary headache. So based on all this, the answer for our question is cluster headache. Okay, right. So this is about the question number 1 related to a type of primary headache, right? I hope this is clear. Most of you answered it correctly as well. Okay, right. Moving on to the second question. Right. A 72-year-old male presents to the emergency department with sudden onset right-sided weakness and slurring of the speech, which began 2 hours ago. On arrival, his blood pressure is 185 systolic, 110 diastolic millimeters of mercury. A non-contrast CT head shows no evidence of intracranial hemorrhage. What is your understanding from this? What is your understanding from this? Yes, this is a sudden onset right side weakness with the speech difficulty. Can you tell me what this presentation tells you about? Sudden limb weakness along with speech defect. Very good. It is a cerebrovascular accident. CVA means cerebrovascular accident or stroke, like that we can remember. Okay, right? So this is a presentation, typical presentation with a stroke. See, it can also be transient ischemic attack. I do agree. But we don't know. Transient ischemic attack over a period of time will settle completely. Stroke will have residual neurological deficit. What I was asking is, at this point of time, some sort of cerebrovascular accident should be thought about. Along with that, the patient is also having hypertension, right? Should not forget that. Patient is having definitely hypertension. Okay, right. Now, in suspected cerebrovascular accident, you will always perform non-contrast CT, which is what was done here. It shows no evidence of intracranial hemorrhage. That means it is not hemorrhagic stroke. Then what is the type of stroke then? What is the type of stroke then? If hemorrhage is ruled out, what is the other variety of stroke? Very correct. It is ischemic stroke. It is ischemic stroke. Right? So that is my thinking at this point of time. It's going to be ischemic stroke. Now I will put up the options. If it is ischemic stroke, what is the most appropriate initial management step in this patient? What is the most appropriate initial management step in this patient? Will you give altiplase, IV altiplase? Will you give intravenous heparin? Will you first lower the BP to less than 160/90 and then start altiplase? Or you will administer intravenous mannitol? Very simple. IV mannitol is for raised ICT management, which can occur as a part of hemorrhagic stroke, which is not the case here. So I am not going to consider IV mannitol. Then intravenous heparin is anticoagulant, which will not be initially considered in the management of ischemic stroke. Definitely for ischemic stroke, thrombolytics are the management, and thrombolytic related options are two. One is administer IV altiplase. Second is lower the blood pressure and then administer altiplase. What will you say? I have seen good number of students answering both option A and some are answering option C also. What is that? First of all, tell me whether the altiplase can be administered or not. See, we have already come to the clinical diagnosis that it is ischemic stroke, right? Ischemic stroke. Why altiplase? You answered that, right? Why altiplase? Altiplase, because it is ischemic stroke. Not only that, look at the time of presentation. If it is within 4.5 hours, that is the best time to administer the altiplase. Now, if you go back to the question, it is clearly mentioned that the patient's symptomatology is for only 2 hours duration. That means he is well within the time limit of 4.5 hours. So, we can administer altiplase, right? Now, also CT rules out hemorrhage. Okay, in a hemorrhagic stroke, altiplase cannot be administered. So, anyway, that is out. So, still I can administer altiplase. Now, the only confusion is the blood pressure, Some of you might have studied blood pressure which is high cannot be in that particular situation. I cannot administer altiplase, correct? Okay. Is it a contraindication for administering altiplase? True, to an extent, only if the blood pressure is more than how much? Only if the blood pressure is more than 185, 110 millimeters of mercury, I will not administer altiplase. Please understand that. If the BP is more than 185 or 110 millimeters mercury only, I will not administer altiplase. But here, very clearly, the blood pressure is how much? It is 180 by 110 millimeters of mercury. It is not more than 185, 110. So, can I administer altiplase? Definitely, I can administer altiplase in this particular patient, and that would be the answer for this particular question. Option A will be the answer for this question. Administer intravenous altiplase. Okay, right? So, now let me ask you one more question. What should be done if the blood pressure is more than 185, 110? You cannot immediately administer altiplase. Here what should be done? You have to first decrease the blood pressure to below 185, 110, and then you have to administer altiplase. Okay. So, the point I would like to emphasize is in the question, if you are thinking as ischemic stroke and if the patient is presenting within 4.5 hours, you have to start altiplase, correct? Only thing you have to watch out is the blood pressure. If the BP is more than 185, 110 millimeters mercury, then I will lower the blood pressure and then I will administer altiplase. If it is less than 185, 110, I will straight away administer altiplase. So that is why for this particular question, the clear answer is option A only. Now this is one of your PYQs. You have to tell me the answer. What should be the dose of altiplase? How much will be the total dose of altiplase? Okay, this is something one of your recent PYQs only. The total dose is according to the body weight. It is 0.9 milligrams per kilogram. Very good. To the maximum dose of 90 milligrams. Maximum should be 90 milligrams, right? Keep that in mind. And out of the total dose, you give the 10% immediately. Very good. 10% immediately as IV bolus, intravenously administered bolus infusion. You give it immediately. Then the remaining 90% you have to give it over 1 hour. Okay, over 1 hour. So this is what is the management of the altiplase in case of the ischemic stroke, right? Dose has been asked as one of your PYQs. So that is about our question number 2. Answer is option A. Okay, moving on to the third question. A 28-year-old male presents with a rapidly progressive weakness of both lower limbs for 3 days, which has now begun to involve the upper limbs also. So that means the presentation is with progressive weakness starting from the lower limbs and progressing towards the upper limbs. What is the meaning of that? It is a ascending type of weakness. Ascending type of weakness. It's an important clue in your question. So from below it goes up. That is what is called ascending. On examination, he has flaccid paralysis with areflexia. Can you tell me, if it is flaccid paralysis with areflexia, what type of weakness is this? Is it a Yeoman weakness or a LMN weakness? Is it a upper motor neuron lesion or a lower motor neuron lesion? Yes, it is LMN, lower motor neuron weakness only, right? It is LMN type of weakness, no doubt about it. If it was human type of weakness, you should get spasticity, right? And exaggerated deep tendon reflexes. But here it is written flaccidity and absent reflexes, right? So this is element type of weakness. That is our next clue. He also complains of palpitations and episodes of postural dizziness. What is that? Palpitations and postural dizziness. These are all autonomic symptoms. These are autonomic symptoms. Autonomic symptoms. Okay, fine. Now we have one more clue in the question saying that lumbar puncture was performed and it shows elevated protein with a normal cell count, normal cell count. What is the meaning of that? The protein or the albumin level is elevated, but the cell count is normal. What is the meaning of this? Yes, this is called albuminocytological dissociation. Albuminocytological dissociation. Very correct. Yes. Now, with this understanding, if I ask you, what is your clinical diagnosis? Look at the keywords from what we have formed from the question. Element type of weakness, ascending type of weakness, autonomic symptoms are present, and one more keyword is albuminocytological dissociation. Some of you already said the answer very correctly. This is a clinical diagnosis of GBS. What is that? Guillain-Barré syndrome. Very correct. This is a keyword, Guillain-Barré syndrome. Okay, right? Very good, right? That is the answer I was expecting also. Guillain-Barré syndrome. Now the question is, which of the following treatment option is not suitable for this patient? Which of the following treatment option is not suitable for this patient? Which is not advised as a treatment option? Is it steroids, plasmapheresis, or IVIG? Okay, now tell me one thing. Which is the treatment of choice or the first choice treatment? Very good. It is IVIG, which will be the first choice of treatment. So that cannot be the answer. Plasmapheresis is the second line or the second choice. We can try. But steroids are not suited as a treatment option in patients with Guillain-Barré syndrome. So that will be the answer for the question, right? So this is purely making a clinical diagnosis of Guillain-Barré syndrome and then going on to ask about the treatment options for Guillain-Barré syndrome. Okay, let me just quickly tell you some PYQ points related to Guillain-Barré syndrome. If you look at pathogenesis of Guillain-Barré syndrome, it's a post-infectious condition. We all know about it. It's a post-infection condition, usually following a gastrointestinal infection with which bacteria? Campylobacter jejuni. This is something important. Campylobacter jejuni. It usually causes the gastrointestinal dysentery type of infection, following which only you get development of autoantibodies. Can you see that? The most important autoantibody, it is anti-GM1 antibody. One more antibody is also there, anti-GD1A antibody also. These are the two important groups of autoantibodies which are implicated. And what will they do? They will damage the myelin and causing demyelination. Okay, right? That is why this condition is considered as a demyelinating disorder. It's a demyelinating disorder. Now, one question which has come in your PYQs is regarding what is the type of antibody they belong to, or what class of antibody they belong to. Anti-GM1 antibody and anti-GD1A antibody, they belong to which type? IgA, IgM, IgG, IgD. Which type of antibody they belong to? Yes, it is IgG type of antibody. This is one of your PYQs. Okay, please note it is IgG type of antibody, right? So this is like a short pathogenesis of Guillain-Barre syndrome where following an infection an autoantibody forms and that destroys or targets the myelin. That's why it's called as a demyelination disorder. Okay. Now also remember 4 important A's for Guillain-Barre syndrome which can be important clues in your exams. And few of that we have already seen in the question. What is that? It's a acute presentation. Very important. It is acute inflammatory demyelinating polyneuropathy. Can you see that? Acute presentation, demyelination or 2 keywords. Polyneuropathy means multiple types of nerves are affected. Motor nerves are affected, autonomic nerves are affected, even cranial nerves can get affected. So this means multiple type of nerves can get affected. Radiculopathy is the same as polyneuropathy also, right? Same. Then second thing is ascending paralysis, right? Very important. Okay, right? I told you start from the lower limb and then goes upwards. Then autonomic involvement. We saw that in the question also. What was that? Palpitations were noted and something like postural disturbances were noted, right? All these are autonomic neuropathy manifestations. One more is a CSF finding, which is albuminocytological dissociation, wherein the albumin levels are increased, but the cell count is normal. These are the 4 A's of Guillain-Barre syndrome that should be remembered for your exam purpose. It is always one of the important and expected questions. So please don't make any mistakes here. So going by all the discussion, the clear answer for this question is steroids are not a suitable treatment option for this patient, right? So that is about this particular question. Moving on to the question number 4. A 45-year-old male is brought to the emergency department with a high-grade fever, severe headache, vomiting, photophobia, and altered sensorium. On examination, he has a neck stiffness and a positive Wernicke sign. Now, with this presentation, fever, some sort of infection, headache, vomiting, neck stiffness, along with Wernicke sign. What are they? They are all signs of meningeal irritation. Meningeal irritation in a patient with fever should make you think about the possibility of meningitis, correct? So this is clinically a case of meningitis we are dealing with. Okay. And if you suspect meningitis, the investigation you do is lumbar puncture. Here also lumbar puncture has been done and it reveals a turbid CSF. Turbid means something like pus containing CSF along with the elevated WBC count with neutrophilic predominant. This is a key word. Neutrophils are elevated. Along with that, there is also high protein and low glucose levels, right? Now, I think with this CSF analysis finding, you should be able to tell me what type of meningitis we are dealing in this question. Very, very clear, especially with neutrophil count high, high protein and low glucose. It is nothing but bacterial meningitis, right? No doubt about it. Okay, it is going to be bacterial meningitis. No doubt about it, right? That will be the clinical diagnosis for this question. Let's move on to the main question. What is the most appropriate initial management step in this patient? Start oral antibiotics and observe. Begin IV broad spectrum antibiotics. Initiate anti-tubercular therapy or start acyclovir. See, only these 2 options are related to bacterial meningitis. So one of that should be the answer. Will you give oral antibiotics? Oral antibiotics are not recommended in this serious infection. Why? Because the oral antibiotics have poor penetration into the blood-brain barrier. And number 2, this is a severe presentation with a quick response needed for which oral antibiotics will not be helpful. So that is out. So what will be the answer? It is begin intravenous broad spectrum antibiotics immediately. As most of you answered correctly, it is option B only. Now, anti-tubercular therapy should be only for TB meningitis. And can you tell me for TB meningitis, what all would be the findings in the CSF? Of course, easy one only. There will be increased amount of which cells? Lymphocytes. Increased amount of lymphocytes in the CSF. Protein count will be too much elevated. That is why I am putting 2 up arrows, meaning too much of elevated protein count is noted. And then what is a characteristic finding in the CSF? Suppose you take the CSF and leave it in a test tube for a long period of time. Yes, it will show the cobweb appearance. It will show the cobweb appearance. These are characteristic of TB meningitis. That should not be forgotten. Okay, right. Now, acyclovir is for Which type of meningitis or meningoencephalitis? Yes, it is virus only because it's an antiviral medication. Yes, it is for HSV1 type of infection. Human herpes simplex virus 1 type of infection, right? Now, what is the feature of HSV1? Yes, it is a viral infection. So, you will get lymphocytes again. You will get lymphocytes. An important point to be noted is normal glucose. Normal glucose. Some of you also remember normal protein for viral meningitis. That is correct only. But for HSV associated meningitis, there can be a mild increase in the protein which can be noted. So what I'm trying to say, just because protein is little bit elevated, don't rule out HSV or viral meningitis. It can be possible. Instead, you look for the other two clues, especially the normal glucose will be a very potential clue in your exams, right? So anyway, that option is also out. So option B will be the clear answer for this particular question. Yes. So option B will be the clear answer. Now just two more quick questions I wanted to ask. You said antibiotic should be started. Can you tell me the empirical antibiotic? What should be the empirical antibiotic? It should be a powerful antibiotic that should cross the blood-brain barrier. Any comment? Yes. Third generation cephalosporin like ceftriaxone or cefotaxime can be used. Third generation cephalosporin, and along with that vancomycin should be started. This is the initial antibiotic to be started if you suspect bacterial meningitis. Third generation cephalosporin with vancomycin. One more quick question. What is the most common long-term sequelae? Long-term neurological problem. Long-term neurological problem. Any comment? What is the most common long-term neurological problem? Very correct. It is sensory neural hearing loss, SNHL. So for that reason only, which investigation you will do for this patient? Which investigation you will do for this patient? Yes, sensory neural hearing loss can be picked up by BERA, brainstem evoke response audiometry. That should be the investigation which should be done for this patient, right? So please keep that in mind. BERA investigation should be done for all patients, okay, during follow-up in case of meningitis. That is also a potential MCQ question. Right, so that was question number 4, which is now completed. Okay, moving on to question number 5. Okay, some sort of discussion was done previously also. I'm just asking that in a different question now. Upper motor neuron lesion is characterized by which of the following? Weakness and spasticity. Second option, fasciculation, rigidity, localized muscle atrophy. What is your answer? What is your answer? UMN lesion is characterized by which of the following findings? Please remember, distinction between UMN and LMN is always a very potential question, whether it's a medicine or a physiology also. Questions are asked in your exams. Okay, you should be knowing about it. First, quick idea about upper motor neuron and lower motor neuron. Okay, from the level of the motor cortex, the cerebral cortex I'm talking about, to the level of anterior horn of the spinal cord is what we call upper motor neuron. Can you see that? This area is what is called the upper motor neuron. And anything below that, from the anterior horn of the spinal cord and below all the way up to the muscles, is what we call the lower motor neuron or the nerves. Okay, neuron is that area and the nerves are coming down, right? Okay. So this is between UMN and LMN. Of course, we can also tell upper motor neuron in terms of the cranial nerves also, like corticobulbar tract and the cranial nerves like that. But generally, we talk about UMN as a corticospinal tract and LMN is the neurons below, right? So this is what is a UMN LMN difference. Now, how do you clinically distinguish between the condition? This is something extremely important for your exams, okay, right? Based on which only this question was also framed. Tone, what happens to the upper motor neuron? Okay, think about upper means above like that. So it is increased. The tone is increased. That is what we call spasticity. Spasticity. Okay. Human, the tone is decreased. Remember as L for low or less like that. This is called flaccidity. Right. So that is number one difference. Number two, muscle atrophy is always a feature of element lesion. It is not an initial feature of human lesion. Deep tendon reflex are very brisk or what we call it as exaggerated, easily elicited in case of human lesion, whereas in element lesion, it is absent. This is what you need to remember. That's what we call areflexia. That is what is called areflexia. That is called areflexia. Don't forget that, right? Then fasciculation. I'm talking about muscle fasciculation or sometimes fibrillation is always a feature of element lesion. It is not a feature of human lesion. Then you must have studied about Babinski sign, right? Babinski sign is elicited by doing a plantar response. Okay, right? We check for the plantar response in the foot area. Babinski sign is an extensor plantar response. Extensor plantar response. It is an abnormal sign. Please understand that, because normally the plantar response should be like flexor, right? The leg should, or the fingers, sorry, the toes I'm talking about should flex actually, but here it will be extension. Okay, that is called extensor plantar. Extensor plantar is always a feature of, yes, human lesion. It is not a feature of element lesion, right? So this difference between human and element is asked in multiple ways in your exam. Even when you solve clinical questions also, you have to make use of this table of differences and then analyze the question, right? So with all this discussion, what is the answer? Some of you have already answered it. Yes, very correct. It is nothing but weakness and spasticity. See, weakness is a very non-specific term. The weakness can be a human type of weakness or an element type of weakness also. But spasticity tells you it is a, yes, human type of weakness. If you talk about fasciculation and muscle atrophy, they are features of element type of weakness. Can you tell me rigidity? Where is rigidity noted? Where is rigidity noted? That is also increased tone only. Yes, rigidity is a feature of something like what you study in Parkinsonism. Okay, right? Have you heard about this cog wheel rigidity, which you study in case of Parkinsonism? Okay, right. So those conditions only you get rigidity, right? So that option is also ruled out. Clear answer for our question is weakness and spasticity. So that was about the question number 5, which is now completed. Okay, right. Now moving on to the next one. Question number 6. A patient is presenting with breathlessness and occasional dry cough. On physical examination, he is found to have bilateral basal crepitations. His pulmonary function testing, that is a lung function testing, reveals decrease in the total lung capacity or lung volume, along with decreased vital capacity also, along with a normal FEV1 FEC ratio. The entire answer for this question is from this part of lung function testing abnormality. What is that? Decrease in the total lung capacity, TLC, total lung capacity or total lung volume, decrease in the vital capacity, and normal FEV1 by FVC ratio. Now, based on the lung function testing, we divide the disorders into obstructive pattern and what other pattern? Restrictive pattern. Tell me, what does this fit into? Decrease in the lung volumes with normal FEV1 FEC ratio. Yes, very correct. It's a restrictive lung disease. Correct? Restrictive lung disease. Now, out of the given options, which is the restrictive lung disease? Bronchitis, chronic bronchitis, idiopathic pulmonary fibrosis, cystic fibrosis, or allergic bronchopulmonary aspergillosis. Which is the restrictive type of lung disease? Yes, it is idiopathic pulmonary fibrosis. In fact, all the other things, chronic bronchitis is a part of COPD, which is an obstructive lung disease. Cystic fibrosis leads on to bronchiectasis, again leads on to obstructive lung disease. Allergic bronchopulmonary aspergillosis is also something related to asthma, categorized under obstructive problems only, right? So, clear answer for this question is idiopathic pulmonary fibrosis. Now, this is something which we share in the regular classes, like a quick difference between the obstructive and restrictive pattern on lung function testing. First one is the most important one, that is FEV1 by FEC ratio is decreased in obstructive lung disease. I have given the number also 0.7, whereas in restrictive lung disease it's usually normal. Sometimes, not saying always, sometimes it can be increased also, right? So this is the first difference. Second, if you look at the remaining 3 parameters, that is peak expiratory flow rate, total lung capacity and vital capacity, sorry, residual volume, all are decreased in case of restrictive lung disease. This is something important. All are decreased in case of restrictive lung disease, whereas peak expiratory flow rate is decreased in obstructive lung disease, but the lung capacity, the total lung capacity and the residual volume is increased in obstructive lung disease. Very, very simple, because the amount of air expiring out of the lungs is lesser in obstructive lung diseases. That is why so much of air gets collected inside the lungs, resulting in increase in the total lung capacity as well as in the residual volume. That is why these two volumes are increased in case of obstructive pattern of lung diseases, right? So this is an important slide. All of you should know this correctly, because one potential question from this is expected in your exam. So please keep a note of this. So going by all the discussion, the very clear answer for our question is option B, because only that follows the restrictive pattern in case of lung function testing. So for question number 6, our answer is idiopathic pulmonary fibrosis. I hope you're able to follow this. Okay, right. Okay, moving on to the next question. A 45-year-old man presents with a sudden onset of dyspnea, pleuritic chest pain, and mild hemoptysis. He has no prior history of cardiac or pulmonary disease. On examination, the respiratory rate is 28 per minute and oxygen saturation is 90% on the room air. ECG shows sinus tachycardia. A CT pulmonary angiogram confirms the diagnosis, right? Now, if you see the starting part of the question till this area, it looks like very unclear, right? Chest pain, something like cardiac. Dyspnea again can be cardiac or respiratory also. Hemoptysis is a clue for potential respiratory problem, but he has no prior history of cardiac or lung problems, right? And ECG shows sinus tachycardia. Again, it is not going to give you any clue to the diagnosis. But the important clinching point for the diagnosis is CT pulmonary angiogram confirms the diagnosis. So, if the patient is having dyspnea and CT pulmonary angiogram confirms the diagnosis, what is your clinical diagnosis? Very good. Some of you already got it correct. This is nothing but pulmonary embolism. See, typically, how do you study pulmonary embolism case scenario? A patient who has been immobilized or bedridden for a long period of time, for example, following a surgery, and one fine day they develop sudden breathlessness, then we think about pulmonary embolism, correct? I do agree to that. But this patient, nothing like that was given, but still CT pulmonary angiogram confirms the diagnosis, will help us to think about the possibility of pulmonary embolism, right? I hope till this point it is clear. Now look at the next part of the question. Which of the following investigation is most appropriate to determine the underlying etiology in this patient? Very important. The question is, which investigation will tell you the underlying etiology of pulmonary embolism? That is what is the question. Underlying etiology of pulmonary embolism. Pulmonary embolism is a diagnosis at present. Now the question is, what is the underlying problem making this patient to develop pulmonary embolism? Okay, type in your answers. Serum D dimer, echocardiography, ultrasound Doppler of the lower limbs, or lung function testing, which will give you the clue for the underlying diagnosis. Or you should tell me what is the most likely underlying cause, or you can tell me what is the source of the pulmonary embolism in most of the patients, almost like 90% of the patients. What is the source of pulmonary embolism? Very good. It is DVT, deep vein thrombosis of the lower limbs. Deep vein thrombosis of the lower limbs. So now tell me, if it is deep vein thrombosis of the lower limb, what investigation will help you to pick up that deep vein thrombosis? Now tell me the answer. Very good. It is ultrasound Doppler of the lower limbs only, right? Ultrasound Doppler of the lower limbs. So option C is the answer. See, now in this particular question, many of you, I can see in the comment section, were answering as D dimer. D dimer. Please understand one point. D dimer is something related to the investigation of pulmonary embolism. Question is not about pulmonary embolism. Question is, what is the source of pulmonary embolism and which investigation will pick up that source? For that, ultrasound Doppler should be the answer. Okay, right? Serum D dimer level is only in the screening for pulmonary embolism. Okay, screening of pulmonary embolism. Right? It will not tell you the underlying cause. The underlying cause can be picked up with the help of ultrasound Doppler, and that will be the best answer for this particular question. Are you able to understand this? See, this question, all of you know it is pulmonary embolism. All of you know deep vein thrombosis is a cause. but you have to connect the wordings in the question. Underlying cause means what is the investigation I do to find out deep vein thrombosis. That is what the question is actually asking about, right? So with all this discussion, the clear answer for our question, is ultrasound Doppler of the lower limbs. Option C will be the answer. Are you able to understand this, right? See, the more and more you attend this type of questions, you know which area you are making mistakes very easily. And this is what we call it as silly mistakes. All these silly mistakes should be avoided only if you read the question properly, right? It is not that lack of knowledge you're getting it wrong. You're not reading the question properly. That's why you're getting it wrong. So make sure this type of mistakes will be avoided in the main exams. Okay, right. Okay, let's move on to the next question. A very direct question, very easy one also. Most of you should be able to tell this. Yes. Which of the following are characteristics of exudative pleural effusion? Before I go to the question, one of you have asked the question, fat embolism. Okay, and how do you differentiate it from pulmonary embolism, right? See, fat embolism will also have breathing difficulty or dyspnea. True. But in fat embolism, there will be additional finding in the form of petechiae. Please understand that in the form of petechiae. Also, there will be some mental status changes in the form of like confusion, patient having some disorientation, something like that, right? That would be the additional features, right? Whereas in case of pulmonary embolism, only dyspnea and some predisposing factors will be given, right? So this is something which you need to know about. Okay, right. Yeah. And also for fat embolism, the usual underlying etiology is some sort of injury or fractures of the bones in the limbs will be given as a clue. Okay, right. So these are the points to support fat embolism. Fine. Okay, right. Now let's move on to the next one. Yes. Which of the following are characteristics of exudative pleural effusion, right? I think this is a very favorite question. All of you must have learnt it multiple times. Just quickly recollect with me. Pleural effusion protein, pleural fluid protein, sorry, to serum protein more than 0.5 s. 0.5. Is it characteristic of exudative pleural effusion? Or in other words, simply tell me, will there be increased pleural fluid protein? Definitely yes. So that is correct. Pleural fluid protein, serum protein less than 0.5 is wrong because it's increased actually. Pleural fluid LDH, serum LDH more than 0.6. Yes, of course, it's again correct. And less than 0.6 is wrong actually, right? So the clear answer actually, correct answer using the code below. What is the answer? It is the 1 and 3. So option A will be the answer for this particular question. Okay, right? Now let me just quickly take you through something called Light's criteria, which is for exudative pleural effusion. This is for the exudative pleural effusion. Light's criteria is for the exudative pleural effusion. And this is very, very important. At least in the last 3 or 4 years, 2 questions have come from this particular section itself. It's extremely, extremely important. Light's criteria tells you if any one of the following characteristics, 3 things I'm going to put up, if any one of these 3 is noted, then you say straight away it's a exudative pleural effusion. You are going to tell me the numbers. Pleural fluid protein bar serum protein more than 0.5 basically tells you there is increased protein uh, in the pleural fluid. That's it. Very simple. Second is pleural fluid protein serum LDH. That is also increased more than 0.6. Third, pleural fluid LDH more than two-third the upper limit of normal. Very important. More than two-third the upper limit of normal. What I am comparing with serum LDH, more than the two-third compared to the serum LDH, upper limit of normal of the serum LDH, if it's more than two-third, then also it's fitting into exudative pleural effusion, right? So any one of this is satisfied, then you call it as Light's criteria positive, and that is suggest of exudative pleural effusion. Watch out for this question. It may potentially come in the upcoming exam also, so don't make any mistake. Simple way to remember is protein and LDH. Okay, sorry, this should be LDH. Okay, right? Protein and LDH will be increased when compared to a normal person in a person with exudative pleural effusion. That's it. Okay, right. So anyway, the clear answer for this question is option A. 1 and 3 will be the correct pointers for exudative pleural effusion. So that was question number 8, which is completed. Okay. Moving on to the next one. Okay, this is pretty straightforward. A 35-year-old man with a history of alcoholism presents with ophthalmoplegia, ataxia, and global confusion. Global confusion means he's not oriented to the time, place, and person like that. Ophthalmoplegia, ataxia, and global confusion. Now, this itself is considered as a triad. This itself is considered as a triad. Can you tell me what is this triad related to? What is this triad related to? Very good. It is nothing but Wernicke's encephalopathy. Correct. It is something related to Wernicke's encephalopathy. Very, very famous triad of Wernicke's encephalopathy. What is it due to? Most of you got it correct. It is due to thiamine or B1 deficiency, which is corrected by giving intravenous thiamine, Okay, right. This is what we remember as Wernicke's encephalopathy, right? Can you see the triad? Ophthalmoplegia, ataxia, and global confusion. Okay, let me ask you one thing. In which group of patients, which patients are prone to develop this Wernicke's encephalopathy? Which group of patient? Number one, alcoholics. Please understand that in your history, case history, they may give like this, alcoholic patients like that. Number two, uh, it's not very common, but maybe in young age group, malnutrition. Okay, severe malnourished patients or malnutrition patients. That is the second category. Third is those who are having hyperemesis. Very, very unlikely. What is the meaning of hyperemesis? Too much of vomiting episodes is present. These are the three group of patients who are prone to manifest with Wernicke's encephalopathy. So if they give it as a case scenario, they may give one of these factors also, right? Okay. So that is why thiamine is given, okay, right, in the management, because it's basically due to thiamine deficiency, okay, right, basically due to thiamine deficiency. So very clear answer is IV thiamine only for this patient. Usually it is given 100 to 500 milligram is the dose. I don't think dose will be asked in the exam, but you should just know at least IV should be the management, right? It's not oral thiamine, it should be intravenously administered thiamine. Okay, right. Now, okay, let me ask you one more question. Suppose this patient was also having hypoglycemia. See, hypoglycemia can also explain some of the symptoms, like confusion can be explained by hypoglycemia. Let me tell you once, okay, let me tell you this. A patient with Wernicke's encephalopathy is also having hypoglycemia. Which one will you give first? Will you give glucose first or thiamine first? You will give glucose first or thiamine first? Any idea? Glucose first or thiamine first? Thiamine should be given. Thiamine should be given followed by glucose. Thiamine should be given followed by glucose. Right. Yes. Yes, thiamine should be given followed by glucose. Can anybody tell me why? Can anybody tell me why? Some of you are saying glucose also first. See, if glucose is given, very important point, if glucose is given, it can cause worsening of lactic acidosis. It can cause worsening of lactic acidosis. Please don't go into the details as of now. I'll just telling you a quick point only. If a patient with Wernicke's encephalopathy also has hypoglycemia, which one should be given first? Thiamine should be given first before giving glucose, because if you give glucose, it can worsen lactic acidosis and potentially the neurological problem can even worsen also. That is why. Okay, right? So this is something like a rule you need to remember. Sometimes question can be framed based on that also, right? Yes. So that's about question number 9, which is IV thiamine. Right. Yes. Very good. Some of you got it correct. Now, this is a very potential question for your upcoming exam, something related to myocardial infarction. A 60-year-old male is presenting with an acute ST elevation myocardial infarction or STEMI, and he receives thrombolytic therapy. Okay, right. Okay, quite a scenario that hospital may have, like started directly thrombolytic therapy. Okay, fine, let's leave that. Despite starting thrombolytic therapy, he continues to have chest pain, and ECG still shows persistent ST elevation. That means the patient is not responding to thrombolytic therapy. Obviously, what should be the next treatment which will be started? It is percutaneous intervention, right? No response to thrombolytic, I will start percutaneous intervention. This type of percutaneous intervention is what we call rescue percutaneous intervention. Simple, rescue percutaneous intervention means you are doing percutaneous intervention after thrombolysis. See, we all know that overall best treatment is percutaneous intervention only. But suppose thrombolysis started and after that also there is no response and you give percutaneous intervention at this time, it's called rescue PCA. Question is, when, at what point of time you should start rescue percutaneous intervention? Is it persistent changes for more than 30 minutes, more than 60 minutes, more than 90 minutes, or more than 120 minutes? This is a straight fact-based question, nothing else. Okay, answer is this one. You should start percutaneous intervention if there is no response to thrombolysis more than 90 minutes of the treatment also you have to start it, right? It's a very straightforward one-liner. It's one of your PYQs also. If I'm not wrong, in 2022 exam, this particular question came. Okay, so just a quick one. When a patient is having failed thrombolysis, you have to do rescue percutaneous intervention. It is indicated in case of persistent chest pain, persistent, this is ST elevation, persistent ST elevation, or patient continues to be hemodynamically unstable even after thrombolysis. That is the time when you have to give rescue PCA, and it should be given if more than 90 minutes have gone after thrombolysis and still the patient has all these problems. Okay, right? Then only you have to consider something called rescue percutaneous intervention. Okay, right. Now, this timeline is very important, I told you, which you have to know by heart. Then two more timelines you are going to tell me, important timelines in ST elevation MI. What is the time between FMC to device? What is the meaning of FMC? First medical contact to device, or what we call in simple terms as door to device time. How many minutes? How many minutes? Any comment? Suppose a patient comes to the hospital, that is called first medical contact time, to the device, that means the balloon device you are inserting or the stent you are putting, whatever it is, within how much of time it should be started? Yes, it is 90 minutes. Very important. It is 90 minutes. This is something important. Door to needle or door to device time. Okay, right. Next is, what is the window period for thrombolysis? Anybody? What is the window period for thrombolysis? Up to how long we can give thrombolysis? Yes. What is that? Up to how long we can give thrombolysis? Some say no, 90 is over. I think there's some lag. Okay, right. 90 minutes is for the door to device. Window period for thrombolysis. Yes, that is the answer I was expecting. It is up to 12 hours. Up to 12 hours. Correct. I am talking about thrombolysis. It can be done up to 12 hours, right? That is what you need to know about, right? Up to 12 hours. Okay, right. So these are all some of the important timelines that you need to keep in mind while solving question related to ST elevation MI. Okay, right. Okay, right. No, some of you are getting confused with this 4.5 hours. The 4.5 hours is the thrombolysis for what? Thrombolysis for what? Ischemic stroke. That is ischemic stroke, right? I am talking about myocardial infarction, right? Both are different. Okay, right. So this is about the question number 10. The clear answer is option C, right? Fine. So now moving on to the next one, that is question number 11. A 70-year-old male presents with a progressive breathlessness and intermittent chest pain. On examination, blood pressure is 150/70 millimeters of mercury and he has a high volume collapsing pulse. Cardiovascular examination reveals the apex beat is displaced 1.5 centimeter lateral to the mid-clavicular line. A high-pitched early diastolic murmur is heard. Okay. I think some of you are again getting confused. Let me clarify that 4.5 hours is the timeline for ischemic stroke. The previous question was related to myocardial infarction. Both conditions are different. Please keep in mind. Okay, right. Okay, I'm moving on to the next question. A 70-year-old male presents with a breathlessness and intermittent chest pain, right? This may be very non-specific complaint. Blood pressure is slightly on the higher side, 150/70. And this is an important clue. High volume pulse, also a collapsing pulse. The other name of this pulse is called water hammer pulse. Water hammer pulse. Yes, water hammer pulse. Okay. Apex beat is displaced laterally. That is okay, but I will just highlight on the point which can give me the clue to diagnosis. Next is a high pitch early diastolic murmur is here. Okay, so water hammer pulse with early diastolic murmur are the two key words which I need to take into account for making a diagnosis. Can you tell me out of the option which is the likely diagnosis? Some of you already have come to the conclusion. What is that? Very good. It is aortic regurgitation. It is aortic regurgitation only. That only has the typical collapsing pulse or the water hammer pulse. That only has the early diastolic murmur also. So very clear, it is aortic regurgitation, right? See, with the keywords, you need to pick up the answers for rheumatic heart diseases. Here it happens to be aortic regurgitation. Now let's have a quick recap of the important or the salient features of aortic regurgitation. One, we have already discussed in the question, that is early diastolic murmur. Second is a pulse, which is already given in the question, called collapsing pulse, also called the corrigant pulse or the water hammer pulse. You all know what is a collapsing pulse means. Rapid upstroke followed by a rapid downstroke. That is what is called collapsing pulse. You can also have other manifestations in the form of dancing carotid. That means carotid artery pulsations are very prominent. You call it dancing carotid. Then in the nail bed area, you can have some pulsation that is called Quincke's sign. That's a very famous sign also, Quincke's sign. And femoral artery also, you can hear sounds, which is what is called pistol short femorals, right? If you can't remember the full list, at least remember the first two, based on which only the question was also framed, and based on which only you can tell the diagnosis for majority of the case scenarios of aortic regurgitation. At least the first two things you need to remember very clearly. So going back to the question, the clear answer is aortic regurgitation in view of collapsing pulse and the early diastolic murmur. Now let me ask you quickly few more questions. In pulmonary regurgitation also, you can get a diastolic murmur, like an early diastolic murmur. Why can't that be the answer for the question? Pulmonary regurgitation, the only condition where it is noted is PAH. What is that? Pulmonary artery hypertension history should have been given, and then the diastolic murmur is given. We may think about pulmonary regurgitation. And the name of this murmur is what is called Graham-Steele murmur. I think it was the last exam question also. Graham-Steele murmur. The pulmonary artery hypertension will lead to sort of pulmonary regurgitation, resulting in a diastolic murmur called Graham-Steele murmur, right? That is something which you need to know about. Okay, right? Okay, so that way we can rule it out in this particular question. Can you tell me for mitral regurgitation, what is a characteristic murmur? Mitral regurgitation. Very good. It is pansystolic murmur. It's a pansystolic murmur in case of mitral regurgitation. That should be kept in mind. The same applies for tricuspid regurgitation also. Mitral regurgitation or tricuspid regurgitation also, it's a pansystolic murmur, right? So with so with all these, we can rule out the other options, and very clearly the answer for this question is aortic regurgitation only, right? Fine. So that was question number 11, which is completed. We move on to question number 12. Listen, see the question carefully and tell me the answer. See the question carefully and tell me the answer. A 40-year-old man presents with a persistent fever for last 2 weeks. Okay, persistent fever for the last 2 weeks. Okay, right. Then blood cultures grow Streptococcus viridans in two separate samples drawn 12 hours apart. Echocardiography reveals a mobile mass on the mitral valve. According to Duke's criteria, this patient meets what? We all know Duke's criteria is something for infective endocarditis, correct? Infective endocarditis. This patient is having infective endocarditis. That is why the question is about Duke's criteria. You have to tell me, it has got major criteria and minor criteria. How many this patient is having? This patient, how many this patient is having? Okay, if you look at the two important clues, one is a blood culture showing the typical organism in two separate samples. This is one of the major criteria. This is one of the major criteria, correct? One of the major criteria. First major criteria satisfied here. Second is echocardiography reveals a mobile mass. Probably this could be a vegetation, correct? This could be a vegetation. Vegetation on echocardiography is a second major criteria here. Second major criteria here. So this patient definitely satisfies two major criteria. Okay, so very simple only. This question tells you about or test you the knowledge of major and minor criteria in infective endocarditis. As simple as it is. So two major criteria is what this patient is satisfying. I hope you are able to follow this, right? Okay. Now you see here. See, some of you were thinking about the fever also, right? True only, but it is not something which is very strikingly given, right? See, fever is not something which is enough. It should be documented temperature of more than 38 degrees centigrade. Then only you will give importance to that minor criteria. Please understand, I know some of you were misled by considering fever as a minor criteria and framed your answer based on that. But temperature should be documented more than 38. Then only you call it as minor criteria. It was not given like that in the question, right? Okay. Now, just a quick recap. Blood cultures positive for infective endocarditis, right? Blood culture positive, which was one of the major criteria that is already given. At least two blood culture positive, it's again given in the question. Second is evidence of endocardial involvement in the form of echocardiography showing vegetation, or it can be like a new regurgitation lesion in the valve can be noted. New regurgitation lesion in the valve can be noted, any one, but in the question it was probably vegetation, so that was also a major criteria which was given. So two major criteria were satisfied in this particular patient one, right? Look at the minor criteria. Patient should have some predisposing factors. For example, RHD. What does RHD means? Rheumatic heart disease, like that could have been given. Number two, temperature, but documented more than 38 degrees centigrade. Third and fourth is vascular and immunological phenomenon. Can you tell me some examples of this vascular phenomenon? Any answer for this vascular phenomenon? Okay, something like infarcts, something like infarct. Okay, anything else? Yes, Janway lesions, nail bed splinter hemorrhages. That's what we call splinter hemorrhages. All these are vascular phenomenon. Can you tell me some immunological phenomenon? Immunological phenomenon. Yes, Osler's nodes. And one more is, yeah, rot spots in the retina. All these things, right? And last one I have written is microbiological evidence. What is that microbiological evidence? Again, blood culture, but single blood culture positive. Remember, if two blood cultures are positive, we call it major criteria. If only one blood culture is positive, we call it minor criteria, right? And at this point of time, you should all remember these pictures. Very, very important for your exams. Okay, important for your exams. Can you see the first two related to the fingers? If it is in the fingertip and painful, then it is Osler's nodes. If it is predominantly in the palm and painless, it is called Janway lesions. Palm and painless, it is Janway lesions. Then bleeding spots, it's actually red in color. Okay, it's not come out well. It's actually like red colored spots in the nail. That is called splinter hemorrhages. That is a nail bed hemorrhage. That is called splinter hemorrhage. Then in the retina, we call it as rot spots. These are important picture based questions for your exam. So you should be knowing about this also very, very clearly, right? So I was just trying to put up some pictures quickly to tell you that it can be asked as potential question, right? So now you can tell me what is the criteria. When will you say that it is suggestive of Duke's criteria? Two major criteria is present. We can call it, we can call it as infected endocarditis, or one major plus how many minor? One major plus how many minor? Three minor criterias, or any other criteria based on only minor criterias? Yes, five minor criterias are present. Any of this can be taken as satisfying the criteria for infective endocarditis. I hope you're able to follow this, right? So anyway, in this question, we have already decided that this patient is having two major criterias, and that will be the answer for this, right? In one of your PYQs also, this type of question had come, not the exact same question, but a modified question has come. And also, good number of questions have come regarding how many criteria are required to make a diagnosis based on Duke's criteria. So, all this related to Duke's criteria is extremely, extremely important for exam. So, please read it very clearly. Yes, so that was about this particular question number 12. Moving on to the next question, that is question number 13. You can read it. A 68-year-old male presents to the outpatient department with the complaints of palpitations and fatigue for the past 2 days. The only significant history is he has a history of hypertension, but he is otherwise stable. Okay, he's coming with palpitations and some fatigability. That's it. Very non-specific. So let's read further. On examination, his pulse is irregularly irregular at 110 beats per minute. Very important clue here, irregularly irregular pulse, which is more than the normal rate, 110. And blood pressure is okay, it's under control only, right? Not very high, 130/80. ECG shows absent P waves, very important, absent P waves and irregularly irregular rhythm confirming atrial fibrillation, right? Okay, so now the clue has already been given in the question that it's a case of atrial fibrillation, right? Even otherwise also, the keyword in this particular question for me is this one. What is that? I am not able to find out a definite P wave. Number 2 clue is irregularly irregular rhythm. That is very, very suggestive of atrial fibrillation, right? So anyway, it is atrial fibrillation and the patient of course is hemodynamically stable. That is why he is coming to the OP itself. Otherwise, he would have ended in the ICU or ER, okay, right? But he is coming to the OP means he is a relatively stable patient only, right? Now the question is, what is the most appropriate initial management for rate control in this patient? Rate control means heart rate control in this patient. What would be the most appropriate step? It's a decision making type of question. Intravenous amiodarone, electrical cardioversion, beta blockers and catheter ablation. Which one? This is a stable patient, so keep that in mind and then tell me the answer. Okay, let me just quickly take you through this atrial fibrillation management part itself. We have to divide it into stable patient and unstable patient. Okay, stable patient and unstable patient, right? Stable patient for rate control, what is the drug you will give? Very good, beta blockers. Most of you answered it correctly. Most of you answered it correctly. And if it is an unstable patient, I have to go for cardioversion, right? Of course, the synchronized cardioversion I have to give, or the shock should be administered if it is an unstable patient. And for rhythm control or to control the rhythm over a long period of time, something like a prophylaxis like that, what is that I can give for rhythm control? Can you tell me rhythm control? What is the drug which is given? Amiodarone. That is what? And even after amiodarone also, still the rhythm is persisting. There is no response. Then I can go for radio ablation. Radio ablation. Radio ablation of what? Radio ablation of the ectopic foci can be done. Right, these are the possible treatment option. These are the possible treatment option, right? So please read the question properly. There are two things which you need to take a note of. One is stable patient or unstable patient. Unstable patient, don't think anything further. It is shock or cardioversion. Stable patient, you see what the question is about. Usually beta blockers for rate control. That is what is acutely required. Then over a long period of time, you can administer amiodarone. There are other antiarrhythmics also which we can administer, but amiodarone is commonly preferred. If there is no response also, then only we go for radio ablation. So now going back to the question, it was clearly mentioned stable patient, rate control was the question. So what should be the answer? Very clear, it's an answer of beta blockers only should be given. I hope you're able to follow this, right? So all these keywords will help you to pick up the answer. If you look at the other option, amiodarone is for rhythm control, not rate control. Electrical cardioversion is for what patients? Unstable patients. Catheter ablation is not an initial treatment option. Only after all the treatment, still the rhythm is abnormally present, then only we can go for catheter ablation or radio ablation, right? So all these options are out and the clear answer for this question is option C only. Now have a quickly look at the ECG tracing in case of atrial fibrillation. When you compare it with the normal rhythm, this is the P wave which we are talking about. This is the P wave which I am talking about. If you look at this, we don't get a definite P wave. That's why in the question it was written as absent P wave. Instead, it is called F wave. It is called F wave. What does the F stand for here? Fibrillatory waves. It stands for fibrillatory waves. Okay, that is a characteristic nature of the wave noted in case of atrial fibrillation. Okay, I hope you're able to follow this, right? So the just a quick recap about the ECG tracing in case of atrial fibrillation. Okay, so that was question number 13 which is completed. We move on to the question number 14. Okay, question number 14. Drug of choice for treating hypertensive emergency in case of aortic dissection. I think all of you know about this. Hypertensive emergency is a condition where there is a very high blood pressure. Along with that, some symptoms or manifestations are present. For example, this patient is already having something like a sort of aortic dissection. Sometimes it can be like a stroke manifestation, hypertension associated stroke, we call it hypertensive emergency, or it can be something like myocardial infarction associated hypertension also. So all these are something like hypertensive emergency, means some manifestation is present, that is what. Is it phentolamine, prazosin, nitroprusside or amlodipine? Which one will be the treatment or drug of choice in this particular situation? Patient is also having aortic dissection. Okay, I think most of you got it correct. The correct answer is in fact nitroprusside only. It is nitroprusside only, right? Okay, I am going to display something from your Harrison textbook which clearly mentions the preferred drugs for different types of hypertensive emergencies. For our question, it was aortic dissection, right? So what is written? It is nitroprusside or beta blockers. Can you see that? Esmolol, labetalol, nitroprusside. That is what it is. Second thing which I want you to remember very clearly is, if the patient is having stroke, then it is nicardipine, labetalol, third is nitroprusside. Usually the first two are preferred. Nicardipine, labetalol are preferred, last will be the nitroprusside. Third thing, of course, all of you should be knowing about, in your obstetrics itself, you have learnt eclampsia. What is the drug? Hydralazine, and the second one will be labetalol, right? So at least from this picture, you need to know these three things, okay, right? Which are potential MCQ questions, right? Which are potential MCQ questions. So please keep a note of this. This is something extremely important for your exams, okay, right? Depending on the presentation or the type of hypertensive emergency only, you have to decide your drug. So coming back to our question, for aortic dissection, it is either nitroprusside or beta blockers. Among the given options, nitroprusside is the one which is fitting. So the clear answer for this question is option C. Okay, so that was question number 14, which is now completed. Okay, moving on to the next question, important one. A 5-year-old boy is is brought to the emergency room following a crushing injury. Something like a trauma, like a RTA, like that, or any form of severe trauma could have caused crush injury in this patient, following which he is coming to the emergency room. The ECG reveals peaked T waves, okay, right? Peaked T waves, that is something like this, pointed T waves like that, right? T waves are pointed. Prolonged PR interval along with that widened QRS complex. Okay. Which of the following treatment should be administered immediately? Sodium bicarbonate, intravenous procainamide, insulin infusion or magnesium sulfate. First of all, you tell me what is the diagnosis in this patient? Crush injury. Okay, it is something like a crush injury. And following a crush injury, what will be crushed? The muscles would be crushed. And due to that, can you tell me what could be the electrolyte abnormality which can be noted? Very good. It is hyperkalemia. Very correct. That is something which we have to suspect. Hyperkalemia. And hyperkalemia is a one which is characterized by the ECG manifestations. Especially, what is the first change of hyperkalemia on an ECG? We all know about. Yes, it's a tall peak T waves, which is already given in this question. Remember, that is the first manifestation. As the hyperkalemia level increases only, you get the other manifestations in ECG also, like prolonged PR interval and wide QRS complex. It means it is not simple hyperkalemia, it is like high elevations of potassium is noted in this patient. So immediately means something which should decrease the potassium quickly. Okay, decrease the potassium quickly. Which one? Very good. Most of you got it correct. It is insulin infusion only among the given options. It is insulin infusion only among the given option, right? This is a quick picture telling you about this treatment options in hyperkalemia, right? See, we have two things to take care of in hyperkalemia. One is decreasing the potassium level. That is the first limb here, you can see. That is the first limb here, you can see. And the second limb is stabilization of the cardiac membrane. These are two things which should be done. Okay, in fact, this is actually the emergency. This is actually the emergency. What is that? Cardiac muscle should be stabilized. For that reason only, you have to give calcium gluconate, which has got an antagonistic action for potassium, right? That is why calcium gluconate should be given as an emergency. That is the first thing I would actually give. Okay. However, that was not given in the question. So I will move on to the other side, which causes the quickest reduction in hyperkalemia. Insulin glucose infusion, beta 2 agonist, potassium binding resin. All these are there. But which is the quickest? Insulin glucose infusion is the quickest. It is the quickest. So that is why in this particular question, I was going for that option. Okay, insulin glucose infusion, right? Then we have the other options like beta 2 agonist, potassium binding resins, all those are okay. But the quickest one is the insulin glucose infusion only, right? Why glucose also is started? Because insulin can lead on to hypoglycemia. For that reason only, glucose also should be added to the infusion, right? Very simple reason. Now, this is one more potential question. If you have tried every treatment option but still hyperkalemia is persisting, or they can frame the question like this: refractory hyperkalemia, refractory hyperkalemia, what would be the treatment you will advise? Answer should be hemodialysis, right? All these are potential MCQ questions, right? So please see the question, what the question is asking about. In hyperkalemia management, to protect the heart, what is the drug which should be given? Calcium gluconate as slow IV should be given, number one. Number two, which is the fastest way of decreasing hyperkalemia? It is insulin glucose infusion. Number three, one-liner, when all the treatment options have been done and still hyperkalemia is persisting or refractory hyperkalemia is there, what should be the treatment modality? Hemodialysis. That is what you need to remember, right? These are three important one-liners related to hyperkalemia. So coming back to the question, the clear answer is insulin infusion, or option C among the options which are given in the question, right? So option C will be the answer for this question, right? So that was about question number 15, which is completed. We now move on to the next one. Very famous question. Comment on the serological report of a patient based on some things which are given as positive or negative. Think and answer. This is a very important question, doctors. HbsAg is negative, something related to hepatitis B. Okay, nothing else. Okay, something related to hepatitis B serology. Hepatitis B serology. Yes. HbsAg is negative. Anti-HBC IgM is negative. Anti-HBC IgG is positive and anti-HBS is positive. Let me focus on the positive ones. What are they? Antibodies against core antigen of hepatitis B virus is positive. Antibody against surface antigen is also positive. I will give you the options now. Is it an established acute hepatitis infection? Or is it the patient convalescence, like early, this is called 3 to 6 months, means it's called early convalescence, or post infection, that means the patient has completely recovered from hepatitis B, or is it only a immunization without infection? Which one? First of all, if it is hepatitis B infection, what should be positive? Tell me that first. If it is hepatitis B infection, what should be positive? HbsAg should be positive. No doubt about it. Is it given like that in the question? It is clearly written HbsAg is negative. So definitely this option is out. Look at the last option. Immunization without infection. What is a vaccine for hepatitis B? It is a subunit vaccine derived from surface antigen only. So if it is immunization patient, only which antibody should be positive? Only anti-HBs should be positive, correct? Only anti-HBs should be positive. But here it is clearly written, not only anti-HBs is positive, anti-HBC is also positive. So that means this option is also out. So can you tell me what is the answer for this question? What is the answer for this question? Yes, two options are possible. If it is a early convalescence, okay, right? Let me just tell you that, right? If it is a early convalescent, please remember anti-HBs is positive or negative. We cannot surely say, right? Sometimes present, sometimes absent also, right? And also you can get IgM anti-HBC also positive. Okay, right? But it is clearly written in the question, it is IgG anti-HBC positive. For this reason, I am ruling out early convalescence also. I am ruling out early convalescence also. And as some of you clearly said the answer, it is option C only. It is option C. No doubt about it. It is option C only, right? Okay, right. Now, this is something extremely important for your exams, doctors. This is interpretation which we have already completed for this question. Second is, I want you to answer this, right? Extremely important. Extremely important for exams. Okay, right? Okay, let me start with the first one. If the patient is in the incubation period for hepatitis B, that means he is having an active infection, right? What all things can be positive? HBsAg will be positive, IgM anti HBC will be positive, IgG will be chronic, so that will be negative. Anti-HBs means patient has recovered from the infection, that is also negative only, right? Because he is having incubation period, right? Okay, even in early hepatitis also, same profile will be noted. For your exams, just focus on this word, acute hepatitis, what all things will be positive. HBs, AG will be positive, IgM anti-HBC will be positive, right? So that is something which you need to focus on. Can you tell me for, yes, no. Can you tell me for chronic hepatitis? For chronic hepatitis, what will be positive? If it is hepatitis, it means HBsAg should be positive, and if it is chronic, IgG anti-HBC should be positive. This two will be negative. That's what you need to remember, right? Very clear. Post-infection means the patient has recovery. The patient has recovered from that infection, right? Patient has recovered from that infection, for which what will be positive? Anti-HBC IgG will be positive, anti-HBs also will be positive. The other two will be negative. It's exactly opposite to acute hepatitis, right? Very simple. Now, this is important as a question. Immunization without infection means what is the only antibody that is positive? Anti-HBs is the only one that is positive. All other things are negative. So, this is something which you need to know as interpretation in HBsAg hepatitis B serology. Extremely important topic for your exams, doctors, right? Okay. So, with all this, okay, so for all this, what is our clear answer for this question? Yes, it is option C. It is post-infection or recovered from hepatitis B. Don't get confused about this incubation period, okay, right? I think you can skip that part also, right? See, this is given in Davidson textbook actually. Incubation period like that is written. It means before even the patient presents with the features like that, right? That is what is called incubation period, meaning he is having the infection but features are not yet manifesting. That's it. So that is why I said these four things you can keep in mind. That should be enough for your exams. Now only one more thing I need you to remember is, if the patient is having acute hepatitis or chronic hepatitis, we can say the infectivity also. We can say the infectivity of the patient also. Can you tell me how is the infectivity based on? It is based on HBe antigen positivity. If the patient is having HBe antigen positive, it means he is having high infectivity. Very important point. He is having high infectivity. If HBeAg is negative, it means the patient is having low infectivity, right? Yes, low infectivity, right? So based on this also, questions have come in your exam. So I feel that this slide is extremely important for your upcoming exam. So you should know it very clearly, and hope we have covered all the essential points also. So that was about this particular question. Answer is option C for this particular question. Is that clear? Okay. Moving on to the question number 17. Yes. Easy question only. Most of you should be knowing the answer. Let's do a quick recap. Wilson disease is characterized by all of the following except. Wilson disease is characterized by all of the following except increased urinary copper, increased hepatic copper, deposition of copper in Descemet's membrane, increased serum ceruloplasmin. Remote infection, I have not come across any particular term like that. Maybe some books it might have been given, but that's not a usual, term when we interpret the serology. Okay, very easy. Wilson disease is characterized by all of the following except, right? Is urinary copper, see, Wilson disease nothing but slow accumulation of copper in the body in which all the manifestations occur. So, increased urinary copper is correct, that cannot be the answer. Increased hepatic copper is also correct, that cannot be the answer. Deposition of the copper in the desmoid membrane, that is also correct because that is only results in what formation? KF ring formation. So, that is also correct. So, what is the answer for the question then? Yes, very clearly this is increased serum copper, because you don't get increased serum copper, you get decreased serum ceruloplasmin. That is what you will get in this particular condition. So, that was a very straightforward question, right? It is decreased serum ceruloplasmin. We all know ceruloplasmin is a copper transporting protein which is deficient in Wilson disease, due to which there is an increase in serum free copper, which is causing all the problems in case of Wilson disease. Okay, right? Clear. Now, let me ask you some quick questions and very important questions related to Wilson disease. Okay, right? Quickly tell me the answer. What is the genetics of this condition? It's an autosomal recessive disorder. Can you tell me the chromosome which is affected in case of Wilson disease? Which chromosome is affected? Very good. It is long arm of chromosome number 13. Okay, long arm of chromosome number 13 is the defective gene which is located. You should also know the name of the gene affected in this condition. That also most of you know about. Quickly tell me the name of the gene. ATP7B gene. That is what is the affected gene in case of Wilson disease. And the main problem in Wilson disease, as we were discussing, is defective copper transport, leading on to decreased ceruloplasmin as well as increased copper inside the body, right? So, this is the basic problem in case of Wilson disease, as we all know about, right? Okay. When we talk about the manifestations of the Wilson disease, it can present in multiple ways. It can have liver involvement or neurological involvement. Please understand, hepatitis and cirrhosis is common in childhood. So, suppose you have a child having Wilson disease presenting to pediatric OP, it will be with a liver manifestation. But adult having Wilson disease presentation will present with neurological problem like ataxia, tremors. They can also have psychiatric disturbances also in the form of anxiety, depression, like that. Eye manifestations we have already seen. Number one is a KF ring. Can you tell me any other eye manifestation? Is there any cataract associated with Wilson disease? Can you tell me that? Is there any cataract associated with Wilson disease? Yes. What is the name of the cataract? Very good. Sunflower cataract. It is sunflower cataract. That is the name of the cataract associated with Wilson's disease, right? Okay. All these are typical manifestations of Wilson disease. Moving on to the next part, you can quickly tell me what is the screening test for Wilson we do? What is the screening test for Wilson disease we do? Two tests are there. One is urine, yes, copper, which will be increased. Second is the serum ceruloplasmin, which will be decreased. Correct? Serum ceruloplasmin, which will be decreased. But please keep in mind, these are screening test only. If there is a question, what is a gold standard test or what is a diagnostic test? What will be your answer? What is a diagnostic test? Yes, it is nothing but liver biopsy. In liver biopsy, you have to look for increased amount of copper deposition. That would be the diagnostic testing in case of Wilson disease, right? So please keep that in mind. Our aim is to decrease the copper inside the body, and this is typically done by copper chelators. What are the copper chelators we know? Quickly tell me. Usual one is D-penicillamine, and one more is a trientine. Okay, the commonly used one is a D-penicillamine as the copper chelator. And second, long-term treatment is in the form of zinc. What does the zinc do? Decrease the copper absorption. Okay, it decreases the copper absorption from the intestine. That's it. Okay, so the initial management will be mainly about chelators and long-term management will be about zinc treatment, which will decrease the copper absorption, right? So I think most of you know about Wilson disease. Please know not only the quick points, you should also know every detail of Wilson disease, because every part of this has been asked in your PYQs in some way or other. So Wilson disease, extremely important topic. So for this particular question we were discussing, the clear answer is increased serum ceruloplasmin is not a feature because you get only decreased serum ceruloplasmin. That's it. So for question number 17, the clear answer Yes, the clear answer is option D only, right? So that was about this question. Moving on to the question number 18. Question number 18. A 48-year-old man with a history of chronic alcoholism presents to the emergency after an episode of severe vomiting. He complains of pain when swallowing. On examination, there is no significant abdominal tenderness. He vomits bright red. He vomits bright red blood shortly after arrival. Okay, right? That means what? He's having uh, hematemesis, right? He's having hematemesis, that is vomiting of blood, hematemesis. Which of the following is the most likely diagnosis? Okay, there are some important clues which are given in the question. He is a patient having chronic alcoholism, number one. Number two, after an episode of vomiting, okay, he is also having pain while swallowing, that is like dysphagia, and also he is having hematemesis. Which of this is a likely diagnosis? Mallory-Weiss, Boerhaave syndrome, esophageal varices, or esophageal carcinoma. This is a very straightforward condition, okay, especially after vomiting, hematemesis, pain while swallowing. This is a very classical case of Mallory-Weiss, okay, right? Mallory-Weiss, okay, it's a Mallory-Weiss. I think all of you know about this. It is a condition which typically follows severe vomiting or retching, especially in alcoholic patients, okay, right? That was a clue which was given in the question also, especially in the alcoholic patients, okay. What is the next one? It is something which is like a tear in the esophagus. It's something like a tear in the esophagus only. But tell me, is it a superficial tear or a deep tear? Okay, it is something like a superficial tear. It's a superficial tear, especially at the gastroesophageal junction actually. Yes, right. It's like a gastroesophageal junction. Superficial tear is noted. And it presents with hematemesis, that is vomiting of blood, along with odinophagia. That means what? Difficulty or painful swallowing, right? He is having odinophagia, that is painful swallowing, right? So that is something important. Location, I already told you. Where is the location? It is at the gastroesophageal junction, right? GEJ, gastroesophageal junction. Okay, right? And you can quickly tell me, how will you make a diagnosis of this condition? How will you make a diagnosis of this condition? What should be done? Yes, what investigation should be done to make a diagnosis of this condition? It is nothing but upper GI scoping, right? Like esophagoscopy should be done, and you can very clearly see the tear also, right? Very clearly you can see the tear also. That is how you make a diagnosis. This is a condition which is usually self-limiting. So all that you need to do is acid suppression. You need to do acid suppression. Say for example, with a proton pump inhibitor, you have to give acid suppression and just observe the patient because it's usually self-limiting. These are the different points about Mallory-Weiss tear which was fitting into our question also. Because in the same question, they may not ask you only the diagnosis, okay, right? They may even ask you what should be the management, what should be the investigation of choice. All these are possible, which is what I have tried to cover in this. Okay. Now, whenever you solve this question, what is that one more condition which can be very doubtful? See, other things and all can be ruled out. What is that? Esophageal carcinoma will not present with hematemesis. It will be like weight loss, elderly patient, and one more is dysphagia. This would be the common complaints in case of esophageal carcinoma. Esophageal varices, what history should be given? What history should be given? CLD, what is that? Chronic liver disease. Chronic liver disease patient having portal hypertension and thereby bleeding from the esophageal varices should be very clearly given in the question, but it is not given like that. Are you seeing any signs of chronic liver disease? Are you seeing jaundice in the question or any other signs of chronic liver disease? Not at all. So that can also be ruled out. The one more condition which can cause some doubt in your mind is the Boerhaave syndrome. So let me tell you how to quickly differentiate between Boerhaave syndrome and Mallory-Weiss tear, because Boerhaave syndrome also can present with hematemesis, and the patient can be a alcoholic patient also, and that will also have a emergency room presentation only, right? Something similar to that only. How will you differentiate? First thing you need to know is the type of tear in case of Boerhaave syndrome. See, the left side one, superficial tear in the esophagogastric junction, is nothing but the Mallory-Weiss, which we have already seen, right? It is Mallory-Weiss. Okay, it is Mallory-Weiss. Wait. If it is a deep tear, can you see that? Deep tear and the lower one third of the esophagus. That means like transmural. Transmural means through and through tear. That is what we call Boyer-Haave syndrome. That is what is called Boyer-Haave syndrome. Okay, right. Now my question is, yes, very correct. How do you differentiate Boyer-Haave syndrome from this particular condition of Mallory-Weiss tear? Which is most dangerous? It is a Boyer-Haave syndrome, which is more dangerous or a more severe condition. Please keep that in mind. Second thing, the patient can present with hematemesis. That is true. But the main feature is acute chest pain. That is how they will present. Okay, right? Acute chest pain. The center of the chest, they will have pain. That is something very important. Second important clue would be subcutaneous emphysema will be noted. Subcutaneous emphysema will be noted. Okay, right? Okay, you can even feel that emphysema also because it's in the subcutaneous emphysema, and you will hear something called as a crunching sound. Okay, right? Crunching sound actually, and that is given a very famous name also. Any of you know that? What is the name of that crunching sound here in Boyer-Haave syndrome called? It's called Hammond sign. It's called as a Hammond sign. It is called as a Hammond sign, and this particular condition definitely requires esophagoscopy. Esophagoscopy, yes, esophagoscopy or CT contrast. This is something important. Okay, it requires CT contrast. This is something important. Why? Because in Mallory-Weiss tear, I told you only upper GA scope is enough. But here, sometimes CT contrast is also required, and this is a condition which requires urgent surgery. I cannot say that it will be a self-limiting condition. It's a very dangerous condition because in this condition, too much of blood loss can happen. Can you see that it's a deep tear. It can even lead on to shock also. It can even lead on to shock also. Right. So these are the ways in which you can differentiate between Boyer-Haave syndrome and a Mallory-Weiss tear. Okay, right? Boyer-Haave syndrome with a Mallory-Weiss tear. I hope you're able to understand this, right? So I was just giving you explanation for this condition also because it can be sometimes confused with Mallory-Weiss tear. For that reason only, I just took up little detailed explanation. Are you able to understand this, everyone? Yes. So with this, the clear answer for our question is going to be Mallory-Weiss tear, right? So can you see that why I am supporting Mallory-Weiss tear? Alcoholic patient following a vomiting episode, hematemesis. Along with that, he is not very sick, right? He is not very sick, right? So that is why I am talking about the possibility as Mallory-Weiss tear. Okay, right. Are you able to understand? Okay, right. So that is about question number 18, which is now completed. Okay, right. Moving on to the question number 19. Okay, question number 19. 19th question starts like a 19-year-old patient itself. Okay, 19-year-old patient presents with a icterus for few days after extensive workout in the gym. Okay, icterus means he is having jaundice following a workout in the gym. Liver function test reveal total bilirubin of 5.2. Can you comment whether this is normal? Liver function test 5.2? No. Total bilirubin is increased. 5 is definitely in the increased range. And they have given direct or conjugated bilirubin is 0.4 milligram per deciliter. Now one more is not given, which you are going to find out with the values. What is that? Indirect bilirubin. Indirect bilirubin. Indirect means what? Unconjugated bilirubin. How much is that? You have to subtract the direct bilirubin from the total bilirubin. That means 0.4 should be subtracted from 5.2. 5.2, 0.4 should be subtracted. How much? 4.8. This is the indirect or the unconjugated bilirubin. So, you can understand in this patient with jaundice, what type of bilirubin is increased? Yes, it is the indirect or the unconjugated bilirubin that is increased in this particular patient. It is the indirect or unconjugated bilirubin is increased in this particular patient, right? So, this is our number one understanding from this. Now, look at the other ones. What are they? AST, ALT, ALP. All the liver enzymes are normal, no problem at all. And past medical history is significant for episodes of recurrent jaundice. Okay, right. So we are dealing with a situation where this patient is having recurrent jaundice along with increased levels of unconjugated bilirubin. That is my summary for this particular question. With this in mind, I will give you the options. You can tell me the answer. What is the possible diagnosis? Is it Dubin-Johnson, Gilbert syndrome, Crigler-Najjar type 1 or Crigler-Najjar type 2? One option can be straight away ruled out. What is that? Dubin-Johnson is ruled out because it is characterized by increased conjugated bilirubin. So for that reason, I can directly rule out Dubin-Johnson syndrome. That is out. Look at the other two options. The last two options, Crigler-Najjar type 1 and type 2. They are characterized by increased unconjugated bilirubin. But this particular condition will start in the neonate itself. It will start in the neonate itself, and without treatment, they cannot survive. Without treatment, they cannot survive. They cannot survive. Right. Now, especially Crigler-Najjar type 1, without liver transplantation, they will not be even able to survive. So look at the question. Is anything like that is given? The patient is on continuous treatment since neonatal period like that. He is having jaundice since birth, but he is not on any treatment at all. That is the important point, right? So without treatment, if the patient is having jaundice for a long period of time, it effectively rules out Crigler-Najjar syndrome. Correct. So with that, the answer for our question is Gilbert syndrome only, because Gilbert syndrome is usually a benign type. Please understand this, usually a benign variety. So even though this condition can have recurrent episodes of jaundice, still they don't require any treatment. Very, very simple. So I was just taking the approach to the question by ruling out the other options also, so that you'll have a better idea about how to approach this type of questions, right? So anyway, the clear answer for our question is Gilbert syndrome only. Can you tell me the basic defect in Gilbert syndrome? It's a condition characterized by mild deficiency of UDP-GT enzyme. All of you should be knowing the UDP-GT is an enzyme which converts unconjugated bilirubin into conjugated bilirubin. That is why when UDP-GT level decreases, it results in increased levels of unconjugated bilirubin. Very simple. It results in increased levels of unconjugated bilirubin, right? So that is number one interpretation which you are able to get in the question itself. Number two, it's always a benign condition. It is recurrent episodes of jaundice, but usually self-limiting episodes of jaundice. Recurrent self-limiting episodes of jaundice. Please understand this. Episodes of jaundice. And this condition is usually precipitated by stress. Precipitated by any form of stress actually. So for example, in this patient, what was given? What was given? Following workout in the gym was given as a stress like that. Some of the patient, what would be the stress? It is something like an infection. Okay, following an infection, any sort of infection, it's like a stressful event for that patient. There they can develop jaundice. So any sort of short-lived episodes of jaundice following a stress, and it is self-limiting. Think about Gilbert syndrome. And these patients do not require any treatment, right? That is why in this case history also, there was no treatment history given even though the patient has recurrent episodes of jaundice. So with all this discussion, our clear answer is Gilbert syndrome only, right? One of you have asked the question, difference between type 1 and type 2 Crigler-Najjar. See, type 1 Crigler-Najjar is complete absent. I am putting minus means completely absent UDP-GT, and type 2 is only deficiency of UDP-GT and not complete absent. If you can recollect, Gilbert syndrome is also deficient UDP-GT, but it's very, very mild deficiency. It's a very mild deficiency, whereas Crigler-Najjar syndrome, it's a significant deficiency of UDP-GT. That's what I want you to keep in mind. Okay, right? So with all that discussion, clear answer for this question is option B only. So moving on to the question number 20. Moving on to question number 20. A 35-year-old woman, okay, a 35-year-old woman is experiencing weakness, okay, experiencing weakness in standing up from a squatting position, okay, difficulty in combing her hair, and is noted to have a violaceous or a heliotrope rash over the upper eyelid. What is the most likely diagnosis? What is the most likely diagnosis, right? Is it polymyositis, dermatomyositis, myasthenia gravis, or rheumatoid arthritis? What is your answer? It's another important question actually. Look at the history. Difficult weakness in standing up from the squatting position. Okay, what is it? It is nothing but proximal muscle weakness in the hip region. Proximal weakness in the hip region. This is saying that hip muscles are weak in this. Difficulty in combing her hair. What is the meaning? The shoulder muscles are weak. The shoulder muscles are weak. And please understand, the shoulder muscles and hip muscles are proximal muscles. So this patient is having proximal muscle weakness. That is number one. And in addition, also having skin involvement in the form of heliotrope rash over the upper eyelid. So now with these clues, two clues, you can clearly tell me what is going to be the possible answer. What is going to be the possible answer? Very good. Most of you got it correct. It's a very straightforward one. Dermatomyositis. Dermato means skin involvement. Myositis means muscle involvement is present. So that is why it is a dermatomyositis. See, if you think about the first option, that is polymyositis, only muscle related features would be present. Only muscle related features will be present. For example, the weakness only will be present. You won't get a skin finding. Myasthenia gravis anyway is ruled out because myasthenia gravis will have what type of features? Yes, diplopia, ptosis, all would be the features of myasthenia gravis, right? Not this type of skin involvement and muscle involvement, right? So diplopia, ptosis would be the features. That is not given in the question. Rheumatoid arthritis, you all know about it. It's something like related to the joint involvement only. Doesn't present with any skin features like a rash. Okay, right? So that is also ruled out. So clear answer for our question is nothing but dermatomyositis only, right? And the muscle involvement is typically in the form of proximal muscle weakness, right? That is what I told you. Difficulty in combing the hair, difficulty in getting up from the sitting position, right? And can you tell me what is this sign called as? Very, very important sign. This sign tells you the patient is having weakness, these areas. What is that? The proximal muscles are weak. That is why whenever he is getting up from a sitting position, he is having some difficulty. What is the name of this famous sign called? It tells you weakness of the proximal muscle. Very good. This is called Gover's sign. This is called Gover's sign. Some of you might have studied about Gover's sign in case of Duchenne muscular dystrophy also. Because in Duchenne muscular dystrophy also, proximal muscle weakness is present. The point I want to emphasize here is, if Gover's sign is positive, don't mark immediately Duchenne muscular dystrophy. Wrong. Because Gover's sign can be present in any condition with proximal muscle weakness. Even dermatomyositis has proximal muscle weakness. So, Gover's sign can be positive in any condition where there is a proximal muscle weakness. You should not say it is diagnostic of Duchenne muscular dystrophy. I hope you are able to understand the point. Right, that is number one. Number two is the skin manifestation. What is the skin manifestation? Something like a violaceous rash. Okay, violaceous rash around the orbit area. What is that? Periorbital area. There is some swelling also noted in the periorbital region, but the name of the rash is important. What is this rash called? Yes, it's called as the heliotrope rash. It was given already in the question, right? Heliotrope rash. Okay, heliotrope rash. That is number one. Number two, what is this finding? Any comment? What you can see is these areas. What is that? Distal interphalangeal joint, proximal interphalangeal joint, or all the joint spaces over the hand, you are having erythematous, that is red color, erythematous papules with scales, okay, right, with the scales, scaly lesions with the scales. What do you call that? Yes, it is called Gottron's papules. It is called Gottron's papules. Correct. That is another classical feature of this dermatomyositis. Any comment on this picture? The third picture, where you can see redness or erythema in the back side, upper back area, neck area, as well as the shoulder areas. What do you call this type of finding? It's something related to the place where we wear the shawl. So that is called as a shawl sign. It is called as a shawl sign. It's called shawl sign also. So all these three are named signs for dermatomyositis? Heliotrope rash, Gotron's papules, and one more is a shawl sign. It is a shawl sign, right? So all these are very characteristic for skin findings, right? Because these are all picture based questions for your exams, right? Now the final part you need to tell me is what is the investigation of choice to make a diagnosis of this condition? Very easy one. What is the investigation of choice to make a diagnosis? Yes, you have to do the biopsy. Muscle biopsy is the preferred investigation. Muscle biopsy will be the preferred investigation where you will see the evidence of inflammation, lymphocytic infiltrates in the muscle. That is the investigation of choice. Tell me, what is the treatment which will be useful in this condition? Itis means inflammation. So some sort of anti-inflammatory medication should be helpful. What is that? Steroids are found to be the treatment of choice in this particular condition to decrease the inflammation, right? So these are all just like quick points about dermatomyositis that you need to know about. So the clear answer for this question, because of proximal nasal weakness and the heliotrope rash, it is a case of dermatomyositis. Okay, one of you were asking me the question, Gover's sign is also seen in, see, Gover's sign will be seen in any condition having proximal muscle weakness. For example, in a child, we may think about Duchenne muscular dystrophy. In older patient, like this question I had given, we may think about dermatomyositis, right? So any condition where there's a proximal muscle weakness, Gover's sign will be positive. That is the point to be noted. So that was question number 20, which is completed. Okay. Moving on to the question number 21, little long question. Let's see that in some details. Yes. 25-year-old man presents with the episodic episode. That means like in between episodes of gross hematuria that often coincide with a sore throat and occasional diarrhea. That means during the time of infections like sore throat and diarrheas, he is also having hematuria, right? So associated with the infection, he is having hematuria. And he reports similar episodes in the past. That means he is having recurrent episodes of hematuria. That is the point. Not a single episode, recurrent episodes of hematuria associated with infection. Okay. His blood pressure has been mildly elevated on several occasions and recent lab results show low to moderate proteinuria, right? So some sort of proteinuria is also there, but significant problem is recurrent hematuria. Okay. And one more important clue is serum C3 levels are normal. This is an important clue. I will try to correlate that later. Biopsy reveals IgA deposits in the mesangium. So now I am going to put up or highlight the three areas. One is recurrent hematuria associated with infections. Number two is normal serum C3 levels. Number three is IgA deposits are noted in the mesangium. With these three clues given in the question, tell me what could be the possible answer or the likely diagnosis. Is it membranous nephropathy, post-streptococcal glomerulonephritis, Buerger's disease, minimal change disease? Okay, please remember, out of these options, minimal change disease and membranous nephropathy, they are nephrotic syndrome presentation, correct? They are nephrotic syndrome presentation. That is ruled out in the question because in this question it's more of nephritis. Okay, right? You all know that hematuria is hallmark associated with nephritis only, not nephrotic. So that is anyway ruled out. The first and the fourth option is ruled out. PSGN is the overall most common cause of glomerulonephritis in a child. Most common cause of glomerulonephritis in a child. Post-streptococcal glomerulonephritis, most common in a child. And is it PSGN in the question? No, it is a adult male who is having the problems, number one. Number two, recurrent hematuria, very important point. PSGN is always characterized by single episodes, very important, single episodes of hematuria. And third important is what will happen to the C3 levels in case of PSGN? It will be low serum C3. Don't forget this. In the question, it is very clearly mentioned C3 levels are normal. So effectively, this option is also ruled out. What is the answer for the question then? It is Buerger's disease only. And what is the other name of Buerger's disease? It is IgA nephropathy. It is IgA nephropathy. And can you see very clearly in the question what is written? The renal biopsy shows IgA deposits in the mesangium. That will clinch our diagnosis of the Berger's disease, which will be the answer for this particular question. Are you able to understand this? That will be the answer for this question. So, Berger's disease will be the answer for this particular question. Okay, right? And also remember, Berger's disease is the most common cause of glomerulonephritis in adulthood. Glomerulonephritis in adulthood. In adults. Please remember this point. Okay, it's the most common cause of glomerulonephritis in adults. Okay, right? Yes. So this is something which you need to know about. So yes, correct. So that is the answer for this particular question number 21, which is completed. So moving on to the next question. Again, one more interesting question. A 68-year-old man with a history of colon carcinoma presents with new onset swelling of the legs and frothy urine. On examination, he has a periorbital edema and elevated blood pressure. His urine dipstick reveals 4 plus proteinuria and microscopic hematuria. Lab testing confirms hypoalbuminemia and elevated cholesterol. Now tell me, what is your clinical understanding of this patient's presentation? Frothy urine, swelling of the legs, that is edema which is present, periorbital edema is also present. Along with that, very important is 4 plus proteinuria, and he is having low albumin with elevated cholesterol. What is this condition? Yes, nephrotic syndrome. This is predominantly nephrotic syndrome. But I should also agree, in view of elevated blood pressure and microscopic hematuria, he is having some nephritis component also. He is having some nephritis component also. Wait. That is what I am trying to say. It is not a pure nephrotic, but he is having some nephritic features also. Nephritic features, predominantly nephrotic feature. That is what I am trying to come to. Now, with this presentation, what is the most likely diagnosis, right? It will be simple looking questions like this, but you have to differentiate between the options. If you see, membranous nephropathy, membranoproliferative nephropathy, focal segmental glomerulosclerosis, diffuse glomerulosclerosis, all are nephrotic syndromes, and some of them can even have nephritic component also. Then how will you decide your answer in this question? You should not forget one important clue given in the beginning. What is that? It is a patient with a history of colon carcinoma. So it means it is associated with malignancy. This condition is associated with malignancy. So tell me, which of these 4 options is associated with malignancy? That will be the most important clue in this question. Very good. Only some of you got it correct. Most of you are thinking as membranoproliferative glomerulonephritis. No, that is wrong. It is membranous nephropathy only. It is membranous nephropathy only, right? First, I will tell you quick points about membranous nephropathy. Then I will tell you how to rule out the other options. Okay. Okay, quickly. Membranous nephropathy. Please remember, it's a condition which is most common cause of nephrotic syndrome in elderly adult. Very important, in elderly adults. If the question is saying that nephrotic in adults, what is the usual cause? It is FSGS. But if the question clearly mentions elderly adults, the most common cause is membranous nephropathy. So this is something which you need to keep in mind. Overall, most common cause of nephrotic syndrome in adults, it is FSGS. Elderly adults, it is membranous nephropathy. You can see in our question also, it is a 68-year-old male, elderly adult. That is something which you need to remember. Now quickly tell me one more MCQ also. Which is the most common cause of nephrotic? Most common cause of nephrotic in a child? In a child, tell me the answer. In a child, yes, it is MCD. What does MCD stand for? Minimal chain disease. These are all like one-liners related to nephrotic syndrome that you need to know about, right? Let me continue the discussion of membranous nephropathy. I just told you it is strongly associated with malignancies, okay, right? Usually solid tumors. Some of the tumors are carcinoma, CA means carcinoma colon, carcinoma lung, and breast cancers. Even in this question, we had a predisposing factor in the form of carcinoma colon like that. So that is also supporting my diagnosis of membranous nephropathy. Third is, it has got the highest rate of thrombosis among all the types of nephrotic syndrome. This is yet another one-liner point, right? See, thrombosis can occur with any nephrotic syndrome, but highest rate of thrombosis is associated with membranous nephropathy. One reason because it is associated with malignancy also. That is the reason which we know about, right? Okay, now let me test your pathology knowledge. In membranous nephropathy, you will see immunoglobulin and antigen deposits, what is called immune complex deposits. Can you tell me the location of the immune complex deposit? I have already given. This is a normal picture of the glomerulus outline or the basement membrane outline. Where are you able to see the antigen antibody or the immune complexes? Yes, it is near to the, or sorry, below the epithelium. Can you see that this area is the epithelium? This is the epithelium or the podocyte. Below the epithelium, you are having the complexes. So please remember very clearly, this is subepithelial deposits. This is subepithelial deposits. And when you see under electron microscopy, it will have something like a elevated outline like this. What do you call this appearance? Elevated appearance. Very correct. Some of you said it very correctly. It's called spike and dome appearance. That's a very characteristic finding. It's called spike and dome appearance in case of membranous nephropathy. Spike and dome appearance. That is a characteristic finding of subepithelial deposits in case of membranous nephropathy, right? So after all this discussion, our clear answer for this question is membranous nephropathy only, right? Okay. Now let me quickly tell me how to differentiate the other options in this particular question. In MPGN, what you need to have is that it is associated with low C3. Very, very important point. Low C3. Was it given like that in the question? Low C3, is it given in the question? Not at all. So that's why I can rule it out. And also this is associated with infections. It is not associated with malignancy. It is associated with infections like hepatitis B virus and hepatitis C virus. Was it given in the question? No. So that is why this option was ruled out. Then, how can we rule out FSGS, focal segmental glomerular sclerosis? This is seen in young adults, not elderly adults. That is why I told you it is the overall most common cause of nephrotic in adults like that, not in case of, elderly. That is number one. Number two, associations are HIV infections and one more is heroin use. Is any of that given in the question? Is any of that given in the question? Not at all. So that can be ruled out. Third one, diffuse glomerulosclerosis. For your exams, the only association for diffuse glomerulosclerosis is what? Diabetic nephropathy. Please understand that. Diabetic nephropathy. So there should be history of diabetes given and then they should have framed the question like nephrotic syndrome like that. Again, it's not given in the question, so that is also ruled out. So because some of you were confused with the options only, I am just trying to tell you how to rule out in a particular question. These are all something like clues which they will use when they frame a scenario question of nephrotic syndrome. So please look out for these keywords and then decide your answers. I hope this is clear. So that was about the question number 20, what was it? 22, which is now completed. Moving on to the question number 23. Very interesting, very straightforward question, easy question also. A 60-year-old diabetic patient can develop which of the following macrovascular complication after 20 years of onset of diabetes? Remember, most of the complication, macrovascular and microvascular also, usually develop late, 10 to 20 years after the detection only, right? So here also after 20 years is a question. This by itself has been asked as an MCQ question in the past. Usually how many years after diabetes, after developing diabetes, a patient develops macrovascular, microvascular complication like that? Yes. Any answer for this question? Which is a macrovascular complication? Yes, it is myocardial infarction only. Okay, it is myocardial infarction only, right? Nephropathy, neuropathy, and retinopathy, they're all microvascular complication. They're all microvascular complications. All these are microvascular complication. Only myocardial infarction is a macrovascular complication because basically it involves coronary artery, which is classified as a big artery or a macrovascular complication. Very simple. Okay, quickly tell me what are the macrovascular complications in diabetes. One is myocardial infarction. Any other complication you can tell me? Stroke, right? Stroke is a macrovascular complication. Third, peripheral arterial disease, peripheral arterial disease, peripheral arterial disease, that is also a macrovascular complication. Peripheral arterial disease, PAD, is also macrovascular complication, right? So this is what you need to know about, right? Some examples of macrovascular complication. One more question I wanted to ask is, can you tell me any infection with increased risk in diabetes? See, in general, a patient with diabetes has more risk of infection. Even wound healing is also poor in a patient with diabetes. I am asking some special infections which are increasingly noted in a patient with diabetes. Anybody? Okay, number one is candidiasis. Candidiasis in the esophagus. Very important point. Okay, candidiasis in the esophagus. The question typically comes like this. A diabetic patient presenting with difficulty in swallowing or dysphagia, and also having white patches in the esophagus, or what we call the thrush in the esophagus. This is something very typical of esophageal candidiasis, right? Dysphagia with white patch or thrush. Please understand, the other predisposing factor for esophageal candidiasis is HIV infection. One more is diabetes. That is what you need to know about, right? Number one. Number two, especially during the COVID time, okay, right? We noted something like this. Diabetic patients with COVID infection or following a COVID infection, they develop something like a black fleshy mass. Black fleshy mass in the nose and the orbits. Any idea what is that called? Yes, it's called, yes, correct. Even that can extend into the orbit and even into the brain also. What is it called? Very good. Rhinocerebral mucormycosis. Very good. Rhinocerebral mucormycosis. It was very commonly noted during the COVID times actually, but in general also it is very important in diabetic patient. Rhinocerebral mucormycosis. It typically presents as okay, black fleshy mass. Okay, right? That should be kept in mind, right? I think most of you answered that correctly as well. Very good, right? So that is about this particular question. So the answer for this question is very clearly a case of myocardial infarction only, is a macrovascular complication. Moving on to the question number 24. Okay, moving on to the question number 24. Yes, right, right. A male patient is presenting with history of recurrent abdominal pain and history of nephrolithiasis. X-ray of the hands reveals the following abnormality. Which imaging should be performed to find the etiology of this patient's presentation? So there are actually two things to be answered here. First, you have to tell me what is the condition, and then you have to tell me the imaging to find out the etiology of this particular condition. First, tell me this. Recurrent abdominal pain is one feature given in the question. Second is nephrolithiasis or the stones is the second feature given in the question. Most important here is the X-ray. Most important here is the X-ray. Can anybody tell me some characteristic finding in that fingers? Okay, a normal finger should have an, I'm talking about the phalanges, should have an outline like this. Okay, should have an outline like this. Normal outline like a rectangular appearance. But here, can you see this area? What is the difference here? This area is supposed to be like missing. Something like that part of the bone is getting eroded, right? That is not present at all. Can you see that? If I take out that, you will be able to see that that part of the bone is getting eroded. Very good. Some of you said it very correctly. It's called subperiosteal erosions. Subperiosteal erosions noted in the phalanges. Noted in the phalanges. So now, with the three clues given in the question, recurrent abdominal pain, renal stones or nephrolithiasis, and subperiosteal erosion, what is your clinical diagnosis? Yes, what is your clinical diagnosis? Yes, it is hyperparathyroidism. 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 Okay, it is hyperparathyroidism. I hope all of you agree with me. This is a case of hyperparathyroidism only. Question is, what should be the imaging to find out the etiology of this patient's presentation? Will you do PET CT, ultrasound abdomen, technetium 99 system AB scan, or X-ray chest? which will be the investigation to find out the etiology. So for that, you need to tell me first, what is the etiology of hyperparathyroidism, right? See, very simple. Hyperparathyroidism leads to hypercalcemia also, correct? It leads to increased levels of calcium also. And that hypercalcemia manifestations can typically present like this way, you remember, like a phrase. What is that? Bones, stones, moans, groans, and psychic overtones. What is the meaning of that? Stones is the kidney stones I am talking about. Bony manifestation I have shown in the X-ray. Moans means in general pain. Groans means abdominal pain. And psychic overtones means something like psychiatric manifestation like psychosis and depression. That is how hypercalcemia symptomatically present. Okay, right? Symptomatically present. Okay, right? Symptomatically present. Now tell me, if there is hyperparathyroidism, what is the most common cause? What is the most common cause? Yes, it is a tumor associated with a parathyroid gland. What is that? Yes, it's a parathyroid adenoma. It's a parathyroid adenoma. Parathyroid adenoma. Yes, that is the most common cause. It's a functioning tumor of the parathyroid gland producing excess amount of PTH. Excess amount of PTH. That increased PTH only will lead to increased calcium and thereby causing all the manifestations. Okay, fine. If you do the lab investigation, of course, you are going to get increased levels of PTH, increased levels of calcium. What about phosphate? What will happen? Phosphate, parathyroid will excrete the phosphate, decrease levels of phosphate, and whenever bone erosion is happening, there will be increased levels of what will be noted? Increased levels of alkaline phosphatase will be noted. This is what is a characteristic set of abnormalities you get in a typical hyperparathyroidism case. Okay, right. Now, going back to the question says, what is the imaging to find out the etiology? What is the etiology I told you? Parathyroid adenoma. What imaging will find out the parathyroid adenoma? Very easy. Is it PET CT, ultrasound abdomen, STEMI scan or X-ray chest? Very clearly, it is technetium 99 STEMI scan. That is a radionuclide scan which will pick up the parathyroid adenoma. That will be the clear answer for this particular question. Okay, clear answer for this particular question. Now, so the answer is option C only, right? Now, quickly tell me, what should be the management of this condition? Acutely, for example, the patient is having hypercalcemia. Okay, patient is having hypercalcemia. What all things can help to decrease the calcium levels acutely? Can you tell me that? Most important thing is IV fluids. You have to maintain proper hydration. That is the most important thing. You have to maintain the IV fluids. Okay, or maintain the hydration status, which can help in the excretion of calcium. Second is which drug? Calcitonin. Correct. Calcitonin. Some of you are saying bisphosphonate also, but bisphosphonate is more of malignancy associated hypercalcemia, as well as for long term or maintenance treatment we can use bisphosphonate, not for an acute presentation. So please keep that in mind. Acute presentation, two things are priority. One is IV fluid, second is calcitonin. Okay, now we know that the underlying cause is parathyroid adenoma. So will I go for parathyroidectomy? Definitely yes. And there are some important indications for parathyroidectomy also. What are they? If the patient is symptomatic. If the patient is symptomatic. Was our patient symptomatic in the question? Definitely yes, I will do parathyroidectomy. Or the second thing is, if the patient age is less than 50 years, if the patient's age is less than 50 years, or in terms of some abnormalities, very high calcium is noted, or patient is having increased levels of creatinine, then also I will go for parathyroidectomy. So practically speaking, most of the patients with parathyroid adenoma will require parathyroidectomy at some point of time. Okay, right? This is what you need to remember, right? See, some of you are telling me the names of the bisphosphonate like alendronate, zolendronate and all. I told you clearly, bisphosphonates are for malignancy associated hypercalcemia. Second is they are for a long term maintenance, not for a acute presentation. Okay, right? So I think you should keep these things in mind. So the clear answer for our question is option C, which is STEMI scan. That brings us to the last question for this discussion. Very important and interesting also. You can just tell me the answer. A 36-year-old patient presents with the episodes of severe headache, palpitation, sweating, and sudden spikes in the blood pressure. That means increase in the blood pressure is also noted. Which of the following test is most appropriate to confirm the suspected diagnosis? Is it urinary metanephrine and VMA? VMA is vanillyl mandelic acid level. 5-hydroxy-indole acid urinary levels, urinary HVA, that is homovanillic acid levels, urinary chromogranin level. And I think for this question, whenever I'm seeing your answers in the live chat, most of you are getting it correctly. The answer is correct. I do agree. But tell me, what is your clinical diagnosis? What is your clinical diagnosis? It's actually three features which should be there. The patient is having repeated episodes of headache, palpitation, sweating along with elevated blood pressure. What is the three important features with elevated blood pressure give you the diagnosis? Very correct. Most of you again got it correct. It is pheochromocytoma. The clinical diagnosis is pheochromocytoma in this particular condition. Yes, what is pheochromocytoma? It's basically a chromaffin tumor, chromaffin cell tumor which secretes a lot of catecholamines, right? It is usually in the adrenal medulla only. It is usually in the adrenal medulla. But few cases are extra adrenal also. You might have studied that. Few cases are outside the adrenal gland also, but most commonly it is in the adrenal medulla only. Second thing, the best initial test. What is that? A product of this catecholamines is something called metanephrines that will be elevated in the urine. So, increased 24-hour urine metanephrine is the initial testing for this particular condition that needs to be remembered. Okay, right? So, that is why if you go back to the question also, what is the most appropriate test? Initial test only. I will do urinary metanephrine and vanillyl mandelic acid levels, but most important word here is metanephrine. Okay, right? It is something like a product of the catecholamines only, which is produced in excess by this tumor. And if I ask you one more question, what is the imaging? What is the imaging test I will do? What is the imaging test I will do to find out the tumor? Can you tell me what is the, yes, what is the imaging test I will do to find out the tumor? I told you it is in the adrenal gland. So, what is the imaging test I will do? CT or MRI of the adrenal gland. That is what I will do. CT or MRI of the adrenal gland. That is what you need to know about. And tell me, what is the role of MIBG scan? One more radionuclide scan. Can you tell me what is the role of MIBG scan? MIBG scan will be done in case of extra adrenal tumors. Very important. Suppose I am thinking of a tumor outside the adrenal gland, I can go for the MIBG scan, or to find out metastatic disease of the tumor also, I can do this testing. Metastatic disease, or to know how far the disease has spread also, I can do the MIBG scan. Otherwise, a straightforward case of adrenal medulla tumor will be picked up by CT or MRI of the adrenal itself. That is what you need to know about, right? Okay. Now tell me, what should be the treatment of this condition? Treatment, of course, all of you will answer that I have to remove the tumor. Fine. But removing the tumor should be done only after controlling the blood pressure. Very important. Hypertension should be controlled, and then only I have to go for the surgical resection. So, now tell me, surgical resection is correct with the pre-operative control of blood pressure. There are two agents to control the blood pressure. One is the alpha blocker, another one is beta blockers. Both will control the blood pressure. See, basically, alpha blockers, what will they do? They control the hypertension, and beta blockers more of controlling the tachycardia. Now tell me one thing, what should be given first, followed by next? Which is given first? Alpha blocker is given first or beta blocker is given first? Always remember, alpha blocker should be given first and beta blocker should be given next. Alpha followed by beta. If you don't do that and if you give beta blockers first, what will happen? There will be unopposed or uncontrolled alpha activity leading to something called hypertensive crisis will happen. So that is why always alpha blockers first, control the hypertension, and then only beta blockers to control the tachycardia. This is the order you need to follow Simple way you can remember A followed by B, that is alpha followed by beta blockers. Okay, this is to prevent hypertensive crisis. So that's about the additional points you need to know for pheochromocytoma. So with all this discussion, the clear answer for our question is urinary, metanephrine and VMA. If both are given as separate options, that is what one of you have asked actually, urinary metanephrine will be the preferred answer to choose. That is why I already put up in this itself. The best initial test is always 24-hour urine metanephrine. So metanephrine is a keyword which you will associate with pheochromocytoma, right? So that was about this particular question. Option A will be the answer for this question. So thank you all for attending the discussion, and I wish you all the best for your upcoming exams. See, answering medicine question is not something which is very difficult, because all of you must have read about those topics. Essentially, from whatever source you have prepared from, you must have definitely come across those topics. The only thing is how you apply in that particular question, because nowadays we see in the medicine questions, okay, lot of clinical scenarios are being asked, and there are few points in the question which if you focus on itself, you will get the answer. But what happens, maybe due to lack of time or you're rushing through the question, you tend to miss out those important words in the question, and that may change the entire answer also. So the only advice from my side is, you know the topics which are going to come in the exam. Only thing is you have to apply properly in the question by reading the entire question. Don't skip any part of the question, especially long questions. And if you do that, sometimes this type of silly mistake or avoidable mistakes will happen, right? If only that part is taken care of, I am very sure that you can get through these exams easily. Don't think about difficult exam or easy exam. Usually FMG exams are at a solvable level for any student who has studied properly, right? Only if you have not studied anything at all, you need to worry about it. But I am sure that all of you who are attending this class must have definitely studied in the last few months properly. Apply it in the exam and try to get the best out of it. So with that, I wish you all the best, and see you soon on the other side. Thank you, and I'm ending the session now.